Welcome to today's episode of the VJHemOnc Podcast, where we'll be sharing discussions featuring leading myeloma experts from the second International Workshop on High-Risk Multiple Myeloma. This podcast is part of the Multiple Myeloma channel on VJHemOnc, which is supported by BMS and Legend Biotech. These supporters have no influence over the production of the content, and this podcast is intended for healthcare professionals only. First, you'll hear from Ross Firestone, Nisha Joseph, and Ajai Chari, who provide insights into immune and targeted therapies in high-risk multiple myeloma. The experts discuss multiple antigen targeting in high-risk disease, GPRC5D targeting, and the role of antibody-drug conjugates.
Hi there, my name is Ross Firestone. I'm an assistant attending at Memorial Sloan Kettering Cancer Center.
My name is Nisha Joseph, one of the myeloma physicians at Emory Winship in Atlanta, Georgia.
And Ajai Chari from the University of California, San Francisco, also myeloma at UCSF.
All right. So we just finished our discussion section at the High-Risk Multiple Myeloma Workshop. And we had a number of interesting discussions about targeted and immune-related therapies. And I think I wanted to review some of that discussion, particularly about a few different topics, the first of which being combining different multi-antigen targeted therapies in a single therapeutic regimen, and sort of how you think the future of that looks in the context of relapsed and newly diagnosed myeloma.
Sure. So one of the things Dr. Voorhees went through is some of the clinical trial data we have targeting multiple antigenic targets at once. So whether that be one compound, like a trispecific antibody, or via two compounds together. So like the redirect study that looked at talquetamab in combination with teclistamab. And I think some of the discussion that we had was looking at how efficacious these combinations or some of these compounds can be, but what are some of the risks or, advantages and disadvantages of each of these strategies? When we think about targeting multiple antigens at once, is that really preferential to sequencing those Is that preferential to sequencing therapies that target different antigens as opposed to doing it all at once? We talked a little bit about potential safety issues and, what that might look like long term.
I think the challenge also is there's three major antigens that we're talking about right now in terms of what's being studied clinically. We have BCMA, GPRC, and then also CD19 in the CARS sector, and of course FcRH5. So if we add that, 4 different antigens in various combinations. And then there's also 3 modalities of therapy, right? We have ADC, bispecific, and CARS. So I think when you put all of those, it's like a stats question. How many combinations and permutations are there? But I think the audience might be interested in also hearing a little bit about each of our presentations. So maybe, Nisha, you could start with your presentation about the ADC.
Sure. So I talked a little bit about the role of antibody-drug conjugates in the treatment of high-risk myeloma. And so a majority of the conversation was around belantamab mafodotin, which is an anti-BCMA antibody-drug conjugate. There are also a few antibody-drug conjugates in clinical trial development, but certainly belantamab we've had commercially before and hopefully we'll have commercially again in the near future in the U.S. And so I talked about a few things. One of the things I talked about was kind of in a larger context, how we can optimize maintenance strategies for high-risk patients post-transplant. And so at Emory, we have long used for over a decade what we call a risk-stratified maintenance approach, meaning for high-risk patients post-transplant, we use kind of an enhanced maintenance strategy as opposed to Revlimid monotherapy until progression. And recently, Dr. Ajai Chari at our institution has designed a trial looking at belantamab in combination with pomalidomide and dexamethasone. And so post-transplant, patients are started on belantamab. What's unique about this trial, in contrast to some of the belantamab trials ongoing and previously published in the relapse space, is the dosing. So some of the issues with belantamab have been ocular toxicity, and a lot of these trials, the belantamab was dosed every 3 weeks, and there was a high need for dose reductions. And so from the get-go, and of course we're dealing with a different patient population, which has a low tumor burden going into a maintenance trial, but from the get-go, the Bela is dosed every 8 weeks with the option then of going to every 12 weeks after the first 2 cycles. So I showed some of that data that was presented at our International Myeloma Society meeting last month, showing really high depth of response. And there's very limited follow-up to date, but so far looking very promising. And then I also talked about some of the high-risk cohort data in the DREAM 7 and 8 trials, which also looked, quite promising, that even in patients with one or more high-risk cytogenetic abnormality, we're seeing that those Bela combination strategies, so Bela in combination with POM or Bela in combination with Velcade, are really able to maintain that high depth of response and PFS benefit even in the high-risk cohort.
My talk was on GPRC, for which we don't have a phase 3 readout yet. So talquetamab, which is the only approved product targeting GPRC, is a bispecific. And what was interesting, I think, with the data update from this year's paper is that PFS for high risk is actually about 18 months versus standard risk about 12 months. And you almost never see high risk patients having a longer PFS than standard risk. So I think that needs to be validated in larger data sets in phase 3 studies. But that's an interesting signal suggesting that maybe high risk patients do benefit. And also older patients had a better PFS. Yeah. But then I think there are still a lot of unmet needs like EMD, double hit myeloma, and prior bispecifics. That's probably the new unmet need because even talquetamab's PFS goes from 12 to 13 months if it's prior CAR T or non-exposed to 3 to 4 months with a prior bispecific. And so we talked about combination strategies that might hopefully improve on these. So Tal-Dara showing a PFS of about 19 months, including in prior bispecific failures. Tal-Dara-Pom also showing exciting data. And then kind of leading back to, I think, Ross's earlier question, the redirect Tec-Tal showing in the initial phase 1 New England paper, encouraging data, but confirmed at this year's EHA and IMS meeting that the PFS in a dedicated, the largest cohort to date of EMD, 90 patients, the PFS was 15 months, which I think is super exciting for this patient population. But I'm curious to get our moderators' input because you've done a lot of work on antigens and combination versus sequencing.
Sure. So I think, but before we get to that, you're hitting a really important point right now in the context of high-risk disease, in the context of these sort of newer generation therapies, in that we're not really sort of seeing the same stratification with our standard high-risk cytogenetic abnormalities as we are with our traditional therapies. But it seems that EMD is sort of one of the biggest things that's coming up as something that's related to high risk with these treatments. And we saw some presentations earlier today where they were talking specifically about EMD and how one of the challenges that they suspect is sort of coming up with these bispecific antibodies is something related to inability of the immune system to penetrate those EMD sites. Yet we see data when teclistamab and talquetamab are used together, we're seeing very high response rates with EMD, despite the fact that these two drugs use the immune system in a very similar way. So I guess my question to the two of you is, why do you think the response rates were so high in that study? And do you think this really provides validity to that approach?
I think part of it, it's hard. EMD, we say kind of loosely, but there's a lot of heterogeneity, right? You can have patients with marrow disease and EMD. You can have a solitary site. You can have a large solitary site. You can also have multiple sites. And so I think part of that is we need to kind of get into a little bit of the weeds of that, because I think there could be pharmacokinetic or pharmacodynamic reason for the failures of these, right? So pharmacokinetic is if it's a bulky tumor, can a drug penetrate adequately? Pharmacodynamic would be, and we've seen some data that perhaps there's heterogeneity in these antigen expressions so that one compound alone doesn't do the trick. You need the dual targeting to really get at that. So I think when you put all of that together, it's hard to have a quick answer to this, but I think it's exciting to see these improvements, and it would suggest that it is more pharmacodynamic, right? Because you're just giving two together. But I think it's also one of the things we brought up is that cilta-cel data, which even though cilta-cel's PFS is worse in EMD, there's still patients with EMD that can do very well. So I think, again, it speaks to the heterogeneity.
I completely agree. And I think another thing we talked about, kind of going to the initial question, is when we're thinking about which patients really should be benefiting from some of these combination strategies, I think most of us agreed in the room that, Tec-Tal, for example, that combination isn't something that we would, utilize for all comers, but might be specifically for those difficult to treat EMD patients. That might be an ideal strategy.
Yeah. I think on the other hand, we have to think of some of the potential risks with regards to these combination strategies, which is what you were getting at earlier, Dr. Chari, which is that with a lot of these therapies, we're seeing pretty significant antigen escape, which is limiting the ability to sequence therapies that have the same target. And so one other thing that was presented during the session today are a couple of new prospective trial designs for high-risk patients at the time of diagnosis, where they're really being hit with all of our best targets all at once. These are the total immune therapy trial that's being discussed, as well as the TRIUMPH study, which are using the GPRC5D-directed therapies, FcRH5-directed therapies, BCMA-directed therapies. Sort of what type of patient do you think you'd consider enrolling on that type of study? And what do you sort of think of the challenges that study is going to present, given that we're giving everything up front and thereby maybe having some challenges with sequencing those therapies later on if it's not a successful regimen in terms of yielding long-term cures?
Well, I think first of all, these are proof of concept trial. So, in terms of long-term complications, I think, you said what kind of patients would we target? I think right now we're really what Ross is referencing is we are designing trials now that we have the idea is, do we have enough therapies? We have such novel, highly effective therapies that are targeting different antigens on the surface of myeloma cells. Are we in fact in a place where we have enough therapies, we have the right therapies that we can essentially get to an operational cure or at least longer term remissions than what we're seeing? And can we hit the myeloma at newly diagnosed when it's the most sensitive? And so these kind of trials, for example, are alternating between bispecific antibodies that might target BCMA or a CAR T-cell therapy that might target GPRC5D or FCRH5, which is Cevostamab, and essentially hitting the myeloma back to back with these therapies in rapid sequence for a fixed duration. And so these are initial trials looking at is this concept, first of all, safe, and are we seeing a signal? And then we can kind of think more about, long-term implications. I think it's particularly interesting for high-risk patients because the standard paradigm or standard approach of induction, transplant, maintenance, we tend to know where that leads for high-risk patients. And so I think it's exciting to shift how we're thinking about approaching those patients and seeing if we do something completely different. Do we in fact get better outcomes? And maybe we won't. Maybe we'll run into, safety issues and other issues. But I think it's a really exciting concept to explore.
Yeah, I think what you're alluding to is there's basically efficacy and safety. Like if so, another way to reframe the question would be, what are the unmet needs in newly diagnosed myeloma? And I would say, frail elderly. So if you have a new immunotherapy that's very safe and well tolerated, that would be amazing because these patients don't always get to the multiple lines of therapy. Right now, let's say, for example, we have current bispecifics approved for 4 lines of therapy. Right? How do you get a frail elderly person to get to 4th line? That's really difficult. On the other hand, from the efficacy side, I would say there's 2 unmet needs. One is, as Nisha alluded to, treatment-free interval. So on the one hand, we're saying Perseus with quadruplet induction transplant maintenance has a projected PFS of 17 years. I'm not sure it's that long, but the point is, that's great, but how do we keep people off therapy if they're going to do that well? And I think the other unmet need, which is the purpose of this conference, is really the aggressive high-risk patients, right? The double hit, EMD, these patients who, again, not because of frailty, but because of their explosiveness of disease, you're not going to get a 3rd and 4th chance to salvage. So why not be innovative and treat them? So it's kind of like, I think I always say that always have lymphoma envy because the pathologists tell you if it's indolent, moderately, or highly aggressive, and you treat accordingly. Right. The pathologists tell us myeloma. It's like, that's go. Wouldn't it be nice to be able to segment patients into those categories and say, okay, novel immunotherapy for high risk, quads for everyone in standard risk, and another novel for frail.
Thank you, everyone, for listening. And thank you to our 2 speakers from this session for sharing their insights. And I hope I'll see you at the High-Risk Multiple Myeloma workshop next year.
Next, Peter Voorhees and Holly Lee discuss mechanisms of resistance to immunotherapy and targeted therapies in high-risk disease and potential strategies to overcome these mechanisms. Dr. Lee shares insights into her work, which has focused on understanding tumor intrinsic factors that contribute to the development of resistance to bispecifics. Dr. Voorhees then outlines several promising therapeutic approaches targeting multiple antigens to overcome resistance.
It's Pete Voorhees from Atrium Health Levine Cancer Institute in Charlotte, North Carolina, and I am here at the International Workshop on High-Risk Multiple Myeloma. And with me today is my good friend and colleague, Holly Lee from Calgary.
Hi, my name is Holly. I'm a clinician scientist from the University of Calgary in Canada.
Very good. So Holly, you and your team in Calgary have led the charge as far as identifying mechanisms of resistance to T-cell redirecting therapies. You want to give us a bit of an overview as to kind of what you guys have gleaned from the research that you've done in your lab?
Yeah, of course. So the main focus of our research is really trying to understand what are the different mechanisms of resistance. And of course, there's, tumor extrinsic, T-cell, tumor microenvironment related factors. But the main focus of our research has been understanding tumor intrinsic factors. And primarily, especially in the setting of acquired resistance to bispecifics, it appears to be hinging on antigen expression and antigen escape. So across BCMA and GPRC5D targeting bispecifics, we're seeing antigen escape rates of around 60%, 60-70%. And that comes in various forms. Studying that genomically, we see that it's either copy number losses, but perhaps more frequently retained expression of the molecule on the cell surface, but with a mutation, so altering the target epitope. So yesterday in our session, we had a great discussion about how that could lead to functional impact and kind of differing sensitivities to different anti-BCMA and anti-GPRC5D targeting agents that we have. But of course, the discussion went beyond that into a discussion of T-cell related factors as well as tumor microenvironment factors by the other presenters.
Yeah, no, incredible work. Do you want to speak to, any potential differences, in this phenomenon of antigen escape with regards to CAR T-cell therapy, BCMA and GPRC5D directed CAR T-cell therapy as opposed to bispecific antibody treatment?
Yeah, so what we're seeing is that for CAR T-cell therapy, the rates of antigen loss seem to be relatively lower, and it mainly comes in the form of biallelic deletion, so complete loss of the antigen. I believe for BCMA, that's about 5%. For GPRC5D, perhaps more frequent. And bispecifics, it's predominantly mutation-based antigen escape that we're seeing. There is also a distinction between BCMA and GPRC5D. So for BCMA, again, it's that retained surface expression with epitope change. But for GPRC5D, a lot of the mutations that we've cloned and tested in vitro are showing just entrapment of that mutant protein within the cell, so it never comes up to the cell surface.
Yeah, no, absolutely. So with all of that in mind, for a patient, relapsing who is fit and potentially eligible for CAR T-cell therapy, based on the work that you and others have done, any thoughts about optimal sequence as far as CAR T-cell therapy followed by bispecific antibodies versus the other way around?
I think we're learning that if you're exposed to BCMA bispecific and you get any kind of subsequent immune targeted therapy, the response rates tend to be lower and suboptimal compared to patients that are completely naive and get it for the first time. And that's with respect to both the depth of response as well as the duration. So perhaps that is partly explained by the biology that we're seeing with these antigen escape. But also, again, I don't want to completely ignore the fact that there's T-cell fitness as well as durability, the tumor microenvironment. I think all of these factors do play a role. So in terms of how we sequence and even combine these therapies, I think those factors all need to play a role. And that's also where the genomics and the functional studies come in to be able to really understand the biology that underlies these subsequent response durations and depths.
Yeah, no, absolutely. And I think, as we kind of move forward into this whole new domain of T-cell redirecting therapy, I think it's going to be critical that we start doing whole genome sequencing on our patients, who are relapsing after CAR T-cell therapy or after they've received bispecific antibody therapy to determine what the deletion status is, what the mutation status is, and what sort of a candidate they are for subsequent, repeat BCMA targeted therapy, for example.
Yeah,
so,
exactly.
Incredibly important work. Now, based on the work that you guys have done and, the 60 to 70%, presence of antigen escape for folks that are on bispecific antibody therapy, obviously from a clinical research perspective, the obvious thing to do is to target multiple tumor associated antigens. And in that regard, we had the opportunity at our center to participate in several, I think, very important clinical trials that are ongoing. One is the Redirect 1 study, which is a study that's looking at the combination of the BCMA bispecific antibody teclistamab in combination with the GPRC5D bispecific antibody talquetamab. The initial phase 1 dose escalation occurred in Europe, but then subsequently was expanded into other regions of the world, including the United States. And to make a long story short, at the recommended phase 2 dose, they saw a very impressive overall response rate of 80% with the combination, which is better than one would have expected, with the 60 to 70% response rates that we typically see with one or the other used alone. And I think, very early days, but the duration of response and progression-free survival that we're seeing with the combination is quite remarkable. During the phase 1 dose escalation, it was very intriguing to see the signal of activity in patients with extramedullary disease, where we know those patients aren't going to do as well with a single agent bispecific antibody-based approach. So there was an expansion cohort that was introduced into Redirect 1, looking specifically at patients who had true extramedullary disease, not paramedullary disease. These are myeloma tumors completely outside of bone. And what we've seen in that cohort of patients, which was 90, really quite a remarkable effort in a difficult, to treat patient population. Overall response rate, again, was around 80%, but more importantly, the median progression-free survival extends, well beyond a year, which is far better than what one would expect with just a single bispecific alone. So it really kind of gets at this idea that, tumor antigen escape is real, and multi-antigen targeting is really a promising way forward to kind of get around at least that aspect of resistance. So, and I think that the other, very interesting sets of data in the clinical domain as far as multi-antigen targeting is in the trispecific antibody space. So we have, the J&J GPRC5D BCMA trispecific antibody, which at the recommended phase 2 dose in patients who've not received previous BCMA targeted therapy yields a response rate of 100%. And the 1-year progression-free survival and duration of response is, well over 90%. So we're really, we're starting to feel the tangible benefits of what you and others have uncovered in the lab. And then lastly, as far as another very interesting trispecific antibody is one that's targeting both CD38 as well as BCMA. Now, when this first came along, I was thinking, gosh, targeting CD38, that's going to be a bit challenging.
Especially after DARA. And,
yeah, exactly. Yeah. And with DARA, we now have evidence that tumor antigen escape with CD38 targeted therapy happens as well. So, but not only that, but the fact that CD38 is expressed on, more, lineages, than just the plasma cells. But, really quite remarkably, when you look at, the phase 1 dose escalation phase of that study, at dose levels 3 through 9, you're seeing, again, overall response rates approaching 80%. And this is a very heavily pretreated patient population, with many of the patients in the study having received prior BCMA targeted therapy. So you would have expected this group of patients not to do as well as they did. And some of them had even had talquetamab, GPRC5D targeted bispecific antibody. So it'll be really fascinating to see how that agent moves forward in the clinic.
Yeah, I think it's a really exciting time in myeloma, as you said, and with these multiple agents coming in at different time points of the disease phase, as well as you mentioned, the newly diagnosed, relapsed refractory, and more terminal. And so I think, we're at a really exciting time. And I think there's a lot to understand about translating these clinical benefits into understanding how they're happening with the biological side, and then putting it all together to see if we can really achieve that cure.
Yeah. No, absolutely. Just one last question. So, obviously, targeting, multiple tumor-associated antigens appears very promising in early looks at the data, but, at the end of the day, that's likely not the only reason for resistance to these T-cell redirecting therapies. So how do you see the field, in addition to targeting multiple antigens, how do you see the field moving forward to overcome intrinsic resistance, that we see with some of the bispecific antibody therapies? Again, your response rate 60 to 70%. So 30 to 40% of these patients don't respond right from the get-go. Yeah. And then, acquired resistance in many cases is due to antigen escape, but again, 30 to 40% of the time it's not. So what are your thoughts about how the field will look like in the next 5-10 years?
So I think, we also look outside of the tumor. I think there's a lot of focus and interest in looking at tumor microenvironment and then the T cells. One of the presentations yesterday was talking about immunogenic cell death, that even though we're targeting BCMA or GPRC5D, maybe the subsequent and kind of the expanding immune effect is there may be antigen spreading and more other epitope-related immunity that may be at play. I think there's a lot to learn in terms of mechanisms of how that initial response happens, but also how it spreads. And for those patients that are primarily refractory, I think we can't ignore the disease burden aspect. Patients who have the very high proliferative and high risk disease up front, maybe they're the ones that are having poor effects. So there is a unmet need in terms of targeting those patient populations more effectively, again, with different combinations or sequences. So I think that's where the field is also headed, and we should also look further into.
Yeah, I could not agree more. With progress comes many questions, but, it's really an exciting time in the field of multiple myeloma, and very hopeful for patients. So thank you for the work that you do on the lab side of things, and we will keep pressing forward on the clinical research side of things and continue to make progress for our patients.
Great. Thank you very much.
Thank you so much for joining us today. For more coverage of multiple myeloma and other heme malignancies, including expert interviews, discussions, and presentations, head over to VJHemOnc.com. Be sure to follow us on X at VJHemOnc and subscribe to our podcast on Spotify, Apple, or Podbean so you never miss an episode.